pediatric and adolescent endocrinologist attached to Jaslok Hospital and Research Center. He is also a department coordinator of SRCC Narayan Children's Hospital, one of the biggest in Mumbai with 281 beds, and is also a chairman of Child Hormone Foundation, and he has published many articles in various textbooks as well as in index international journals, and he has been a regular speaker at various conferences. Hi, Dr. Abhishek Kulkarni.
Good afternoon.
I welcome you. Today we are going to discuss on a common problem which we face when we attend a baby at the time of delivery, or in our practice a case of congenital hypothyroidism, which is one of the commonest reasons of intelligence limitations, or you can say delayed mental health. Dr. Abhishek, congenital hypothyroidism, how common is it? What is the incidence in your experience?
Yeah, so global prevalence of congenital hypothyroidism is said to be 1 in 2,500 live births. We do not have uniform data from our country, but pocketed studies from across India quote a much higher incidence of up to 1 in 2,000 live births. So, which is pretty common if we consider the incidence of live births in our country.
Yeah.
So, assuming 1 in 2,000 to 2,500 babies born in our country would be afflicted with this condition, it assumes great significance.
Yeah. So, keeping this incidence in mind, now we heard that it has been advised to neonatal screening for hypothyroidism in every baby which is practically born. So it is really required.
Yes. So one of the most important messages from this program is going to emphasize to the pediatrician that screening of every baby for congenital hypothyroidism is not a luxury but the essential right of every newborn.
Correct.
So keeping the fact in mind that it is one of the preventable causes of intellectual disability and the high incidence globally of this condition, it is imperative that in today's modern age every baby born undergoes screening for this particular defect.
Okay. Is there any way to clinically pick up a case of hypothyroidism when child is born?
Yes, so that's the most important question often asked by practicing pediatricians to us at various academic fora. And the myth even today is that a baby with congenital hypothyroidism is a baby who looks coarse, who has a large posterior fontanelle which is open, who has a large tongue, has protrusion, has umbilical hernia, jaundice. But what we need to understand is only 25% of babies exhibit these features, and 75% look apparently normal at birth because of the maternal T4 crossing the placenta and preventing the development of symptoms. And by the time these 75% of babies who are asymptomatic at birth show clinical features, it is usually 6 to 8 weeks postnatal, which is too late to salvage complete intellectual functions.
Okay. So now, not to miss these anatomical defects or dysgenesis, after the first neonatal screening test, when you do this technetium scan?
Yes, so it could be done immediately. Contrary
so all
to
babies where it is positive, you will do immediately?
Yes, so what we do is as soon as your screening sample results are available, and if they are suspicious for congenital hypothyroidism, we go ahead and do a repeat sample between day 7 and day 10. So if your free T4 is low and your TSH is high, you immediately proceed towards a nuclear scan and or an ultrasound at places where the nuclear scan is not available. But if your free T4 is normal and your TSH is high, then you wait for day 7 to day 10 confirmatory sample. And here, if your TSH keeps rising and whether your free T4 is normal or low, then you proceed for the anatomical diagnosis.
Okay. Now, if there is a central hypothyroidism, as you said, when TSH is produced low, what other tests you will do?
Yes, so usually the hint for the pediatrician is central hypothyroidism is not occult. It does come with certain other comorbidities like a micropenis or a cleft lip palate, other midline defects, giving us a hint that this hypothyroidism is not coming in isolation. Also, an important clinical marker which we have studied over the years is in primary congenital hypothyroidism, the hyperbilirubinemia is of the unconjugated type, whereas that in secondary hypothyroidism it is usually of the conjugated type because of concomitant ACTH deficiency. So yeah, a simple bilirubin by an intelligent pathologist could help you delineate between the two, and presence of micropenis, hypoglycemia, prolonged conjugated jaundice are markers that this hypothyroidism may be the 1 in 50,000 rarer type, where doing a cortisol and replacing hydrocortisone if the child is adrenal insufficient is extremely important, because thyroxine in an unreplaced child with adrenal insufficiency provokes an adrenal crisis.
That's a very important clue.
Yes.
Okay, so other than neonatal screening by doing blood tests and not waiting for physical features to develop, can this prolonged jaundice be a good indicator?
Yes, it does. Prolonged.
You may not delay if
Yes.
suppose you are not done the initial
Yes.
screening.
So prolonged unconjugated jaundice in fact is one of the pick-up signs of congenital hypothyroidism. Unfortunately in our country screening is still not universal, and quite often a referral is made after the pediatrician detects a high TSH during investigation for hyperbilirubinemia.
Correct. Abhishek, once we have picked up the diagnosis of hypothyroidism, how will you manage and treat?
Yeah, so the dictum is to treat early after confirmation of the condition. If possible, if you have access to nuclear imaging and or ultrasonic imaging, it's always wise to confirm the etiology. And once you have done that, however, the important message here is to not delay treatment for the want of scans and ultrasound, because the prime motto of the pediatrician is intact survival.
Correct.
You need intact neurologic outcomes as these children grow older. You begin thyroxine in a dose of 10 to 12 micrograms per kg. Some of my colleagues would argue that higher doses, higher doses achieve faster therapeutic levels of free T4 in the blood. However, we do not have long-term data on higher doses like 12 to 17 microgram per kg, whether actually achieving higher free T4 levels translate into better IQ scores when these babies are 5 or 10 years old. And we still stick to the age-old practice of 10 to 12 micrograms per kg. Yes, in a severe deficiency when the referral is late, we would like to escalate the dose and achieve free T4 levels faster. The first thing the pediatrician must do is check a free T4 level after 15 days of starting the treatment. The TSH takes about 4 weeks to come back to normalcy, and it would not be wise to repeat the TSH early and get paranoid and start increasing the dose. All that the pediatrician needs to do is to do the TSH between 10 to 14 days, and if the free T4 level has crossed the mean for age, you know your dose is doing a good job. And then at 4 to 6 weeks, you do your free T4 and TSH, and if your TSH is now well within 5.5, you know you're doing a decent job. However, on prospective follow-ups of these babies, the therapeutic targets currently recommended are to keep the TSH below 3.5 on treatment. So though the diagnostic cutoff is a TSH above 10, while on thyroxine, most world bodies recommend keeping the TSH to below 3.5. This is because the TSH and the free T4 share a beautiful logarithmic inverse relation, and if your TSH is below 3.5, your free T4 is supposed to be above the +1 standard deviation for that particular chronologic age. So in resource limited countries like ours, where you wouldn't want to increase the cost of testing for the patient, is doing a TSH alone is good enough in primary congenital hypothyroidism. And if you have maintained the TSH below 3.5, you know your free T4 is as desired for the age.
But the first monitoring sample after 15 days will be free T4.
Absolutely. The first
Later
sample,
on
yes. So first one will be free T4. Subsequently, in the first 6 months, every 6 to 8 weeks, we would like to do a combination of free T4 and TSH if resources are not a constraint, and if resources are a constraint, second sample onwards, it can be only TSH in primary. Whereas in secondary congenital hypothyroidism, only a free T4, because there is inherent TSH deficiency. So there's no role of doing TSH in secondary congenital hypothyroidism.
Once you are diagnosed, you have started the treatment, how long to continue the treatment? when to decide that it is cut off age, like you said after 3 years you can stop and see a trial, whether it's worthwhile doing in every child other than the central hypothyroidism or in certain cases?
Yes. So once we have documented that there is a permanent etiology to the congenital hypothyroidism, you speak to the family right there at diagnosis that the need for thyroxine is going to be permanent and lifelong. Similar is the case in central or secondary congenital hypothyroidism. You tell the family unequivocally that there should not be an attempt to miss the dose.
Yeah.
However, in cases where an etiology has not been discerned or documented, in cases where the TSH and FT4 remain normal on very low doses of thyroxine, in these two cases, it would be wise to take an assessment of permanency test at 3 years of age. We wouldn't like to do it before 3 years. However, there are papers which talk of discontinuation of thyroxine by age 2, because literature says 95% of your brain is myelinated by age 2, whereas 97% of it is myelinated by the 3rd birthday. So we would like to play conservative and continue the thyroxine till age 3, and then take a call on discontinuation by doing an assessment of permanency test, where we stop the thyroxine for 15 days, repeat the thyroid functions, and if the baby is euthyroid, you continue the discontinuation and keep monitoring the thyroid functions. And if your TSH starts climbing up, you know this is permanent congenital hypothyroidism, and you start treating. A special scenario is where your minimal doses of thyroxine keep causing iatrogenic suppression of TSH, even at doses as low as 12.5 and 25 microgram in a baby less than 2 years of age. You know this baby might have outgrown the need for thyroxine, and there you may not wait till the 3rd birthday, but maybe take a trial even before that. But these are rare exceptional circumstances, and please note that when a trial of thyroxine is being taken, the compliance and the follow-up of the patient is extremely critical, that they come back to you at 2 or 4 weeks and show you the results. Because if the trend is again of a rising TSH, you know this is permanent. Yes, so there can be an intellectual mishap. Yes.
Now initially you said we should monitor every 15 days or maybe a month. Then how frequently and till how long we should be keeping monitoring the levels?
So the first test that we do after initiating thyroxine is a free T4 at 15 days. Subsequently, a combination of free T4 and TSH at 6 weeks, and then every 6 weekly or maybe 8 weekly till the baby is 6 months old. And from 6 months to 3 years, it has to be monitored every 3 months.
Okay.
Once the child is older than 3 years, where your neurologic fears have reduced, you could monitor the thyroid function once in 4 to 6 months subsequently.
Okay, so that's very good. Now, a child with hyperthyroidism, if treated in time with proper dosage, with proper compliance, and you have ruled out every other possibilities, what are the prognostic factors, or what is the likelihood of child developing good cognitive function and less mental damage?
Yes, so fortunately, at least in urban India, we have now evolved from mental retardation in congenital hypothyroidism to subtle neuromotor deficits. Earlier, we used to see mental retardation or gross intellectual limitation because these babies would be detected late, maybe months postnatal. But now with the advent of screening programs in private hospitals, in bodies like Indian Academy of Paediatrics, and piloted places where screening is being done, usually the baby is on thyroxine latest by 1 month postnatal. In such babies, we do not see gross limitation of intellectual functions if everything has been done appropriately within day 14. Unless the mother has had hypothyroidism and she has been inappropriately managed in pregnancy, what we need to understand is in the first 12 weeks, the baby is athyrotic. The baby does not have its own thyroid. And if the mother has hypothyroidism herself and is inappropriately managed, the baby may still suffer cognitive insult in spite of the pediatrician having done his best and treated the baby within day 14. But if the mother has been euthyroid throughout gestation and the baby has been detected and treated within day 14, we do expect normal intellectual quotient outcomes in these babies. However, again, there are two caveats to this statement, is that subtle neuromotor deficits like language acquisition, arithmetic abilities, left to right hand coordination, low decibel sensory neural hearing ability may still be dysfunctional in these babies
even if
they have been treated within day 14, and the world is hypothesizing this to the lack or the mutation of transcription factor expression both in the thyroid and in the brain. So these cases are more seen in thyroid dysgenesis due to transcription factor mutations rather than sporadic congenital hypothyroidisms. But when you encounter dysgenesis or hypoplasia or agenesis of the thyroid gland, and you are able to do genetic studies and isolate it to thyroid transcription factor 1 or 2 mutations, then this theoretical possibility has to be spoken to the mother and the family, because these transcription factors are also expressed in the brain in these particular areas.
So while counseling the parents, we should say that most of the time they will be okay.
Yes.
But there may be some defect in all these type of subtle functions or cognitive functions, so that they are mentally prepared to accept it.
Yes. So in fact, in the West, people don't speak of mental retardation with congenital hypothyroidism anymore. Most of the current papers talk of deficits in these subtle neuromotor functions as a sequelae of congenital hypothyroidism rather than gross mental retardation. And with programs like these, we are hoping that India soon will embark on a journey where even we will talk of subtle neuromotor disabilities, rather than mental retardation.
So what will be the effect on sexual life of a child who has been diagnosed well in time and treated in time? Will it be affected?
No, it should not be. It should not be. However, some cases where detection of congenital hypothyroidism has been missed, and these infants or maybe early toddlers reach us from the periphery of the country, we see macroorchidism with very high TSH values. And this is because both the TSH and FSH share a common alpha subunit, and the high TSH spills on this FSH receptor and causes relative macroorchidism. These unfortunate children are intellectually limited by this time, and quite often pediatricians like to think of genetic syndromes like Fragile X in them because of the large testes and the intellectual limitation, and a TSH or a thyroid function is not evaluated, which should not happen. But a baby detected and treated on time, if not associated with any genetic syndrome, should have a normal physical development.
Any other treatment part you would like to add, or is it enough?
I think thyroxine is the gold standard for treatment of congenital hypothyroidism. Timely administration of thyroxine, adherence to the therapy, highlighting to the family how important it is that a dose of thyroxine missed may pull the free T4 levels down. Highlighting this fact is extremely important. Periodic monitoring should have excellent outcomes in primary congenital hypothyroidism.
I think you have got given us a good, nice take-home message that congenital hypothyroidism should not be missed, and government should be proactive in putting up this program for every baby, so that not a single case is missed. And we should be at the level of Western country of saying that there is no question of mental retardation. Maybe we are dealing with some
absolutely. So with programs like these and with the screening with Indian Academy of Pediatrics under your able leadership, we should be proposing a draft to the government of India to make screening mandatory.
So let us prepare a white paper on that.
Absolutely.
And we'll put it up with the government.
Absolutely. So the final message is screening for congenital hypothyroidism is an essential commodity for every newborn who takes birth in our country.
It's not to be taken as luxury, it's a must.
Absolutely.
Okay. Thank you very much, Dr.
Thank you.
Abhishek.
Thank you.
Yeah, thank you.